So now I'm going to welcome Dr. Peake. Dr. Peake is a cardiac surgeon with 40 years of government service, retiring from the Army as the 40th Surgeon General of the Army and returning to government at the 6th Secretary of Veteran Affairs under President George W. Bush. He has served as Chief Operating Officer of a non-for-profit humanitarian organization and a for-profit medical examination company. A member of the CGI Federal Board and Senior Vice President of CGI since 2009. Dr. Peake has had roles including responsibility in health industries. He currently serves as President of the American Telemedicine Association. So thank you, Dr. Peake, to be here today.
Well, I appreciate the chance to be here and to follow the excellent presentations that we've had so far. We've got my slides here. Do you want to go back to what we had before? It'd be okay. This is an exciting topic, and I'm not an academic, so I'm going to talk to you really about some perspectives from two large mental health systems in the United States, and then the perspective that I've had really focusing on one of our customers at CGI, but I can also maybe comment about some of the Nordics and others that systems in which we work really across the globe. So first of all, I spent about 40 years between DoD and the Veterans Health Service in the United States. And it's, as I say, I'm really not an expert, although I do have a briefcase and gray hair or whatever I do have. But, you've heard from the experts. I'm going to give you sort of observations from living in the trenches across these organizations. First, these are really just a level set for y'all. They're really two different systems, the DoD, Department of Defense, and the Veterans Administration, the Department of Veterans Affairs. Each of them are about better than a $50 billion system operating. And so I'm taking a little bit, Ross, up from the micro, which I absolutely agree is fundamental and important. But really a bit more of the macro of the systems that support that micro look. I'm going to first talk about the Department of Defense and the military health system. My experience comes from really the Army, where I've spent most of my life, but I will show you as we walk through, it's been increasingly a joint engagement and an inexorable movement forward in terms of systemness, if you will. I would suggest to you that this, bottom line up front, I think this is more of an evolutionary rather than revolutionary move to systemness in the military, and I would suggest to you also in the civilian world. I will tell you that I think there are inflection points along the way that kind of make those boosts along the evolutionary way. Started to put a picture in here of a hog trying to butcher itself. Couldn't find a good one, but I think there's an issue that you got to think about in terms of that. I will point out this here that says the Army has been around since 1775. The Army Medical Department was formed in 1775. The Navy, 1842. I was the 40th Surgeon General of this organization. A lot of changes over the course of that, over that period of time. But there's a lot of tradition, a lot of culture, a lot of pride and history that goes into that organization. And so change is always difficult when you have those kinds of things, but it is forced by the continually changing environment around it. So And I will spare you the history between 1775 and 1973, but I will tell you that in 1973, that was when we were coming out of the Vietnam era, if you think about it. So a time when everybody's re-examining what you should be doing and how you might want to look as an institution. Before this time, the hospitals at the various post camps and stations around the United States really belonged to that installation commander, not necessarily a medical commander, but an installation commander that might be an infantryman or artilleryman or whatever. And that's where the budget sat, and that's where, even though the Surgeon General was the policy lead at the top of up at the Chief of Staff of the Army's level, and made policy and so forth. The issue is, how was that translated down? And it was mostly affected by that installation commander who may believed in good medicine, or may said, well, that's where I'm going to take my budget cuts and do my training of my soldiers. So, 1973, we formed the Health Services Command, and that put all of those hospitals under General Spurgeon Neal, who had been around for a long time in Korea and Vietnam and so forth, a really respected leader. And so we had a unified system. General Neal and that Health Services Command reported to the Chief of Staff of the Army, basically, not to the Surgeon General of the Army, who was a policy guy over here, also advising the Chief of Staff of the Army, but he didn't have operational control of those medical units. Okay, 73 to 1994. What happened in 94? We were coming out of the first Gulf War, when you think about it. So we had the experience of taking the Army to war, falls in that from a system. You know, some of you want to be restructuring the to sort of save money and improve. So, we went through, if you will, so structures of people. Really, it's a realignment of these. So we overlap policy because the Surgeon General for the peacetime and the go to war also became the medical command, and that, where all came under the Surgeon General. The preventive medicine, the research and medical, the training and the medical. And I just both about the importance of the human leaders and so forth brought under, so the Surgeon General really sort of authority. How do we structure it into regions? Several times since reasons which we can chat about. This is just to give you an example. The Pacific into three and Europe regions, a Pacific region, a European region. Those regions come general responsible for within those of the central region anchored on a major Army medical center located around there, but what the Surgeon General. So really, each of them has a because those all need to work in coordination. Just at each nation's, the commander of the medical unit, if you will, of the medical. Also, the director of health for the installation, reaching down into the community. Heard about this responsibility for all of the other community he has in place. When I was a surgeon, you may recognize the scorecard, Lynn Norton. I turned it on its head. These are the mission. This is sort of the top of our sustain, healthy, and medicine about taking care of the soldier. The stakeholder that's looking at here that wants to make sure his trained and equipped medical support the soldier off to war. Staff of the Army is going to be really, and then managing the military family, because system takes care of duty military, the active retirees, and that's a little different than that later. Some of these bullets on here really talk about passion for healthy patients, eliminating that, and then a positive effect. Similar to what we are replicating down there from this. So each of these were the outcomes that we wanted. And you say, what is it that we wanted? Audio perhaps. Okay, so what is it that we have to do? Again, as a realizing that we've got to put enough in the sector of and it is talking to the complex things that have to have each of these bubbles was supported by then it talks you need to have. Well, we want quality people. We want to train the medical force. We put down here is we enabled essentially to have supports this whole thing together. The IT people says no. Your whole organization, a separate initiative. This pushed throughout every piece of it. Responsibility we put down at the top of the system. And then we cascaded it. This was at the and we cascaded it, and each of those went down to next hospital and clinic. so that as we sort of heard and tried, what we want, the common vision, the common understand that they have to meet their, but it also allowed with the approach. So that we used in survived 4 certain journals, and now DoD is approach. But it was a community as well as a management tool. Every one of those initiatives became that went on a regular basis. So to do that, we needed a support center that really in with more we had actually to a point. Working for internal clarity on the sources is the first thing anybody says with my data. That's not right. And you go down, and it's fundamental to running having information. And I think that allows us for you, as I mentioned, was part of use it to actually run on, and it was linked to that philosophy. And this is a slide in 2000 when I built this slide. It's true today. It really fundamental around the page, and that starts to their system, which we were taught in those days, quality issue, decision support, and so. So this was a specific approach. This is pretty self-contained with that point. We had an executive history, so I had responded to the Army for things, institute forces, medical, and so forth. We're really shared services, for the other services, the Air Force, the Marines, but we had really an integrated at that. So what else changed? Single pot appropriation across in the Air Force. So it has changed. Contracts let for network eye care back in it was on today, where more contractors that we didn't have the capacity with the beneficiary outside within, and we created. I was the first TRICARE in our Northwest. Responsibility for administrative $1 billion contracting, that we talked, as well as commanding the center of the mothership. Being the Navy and the Air Force authority, really Air Force, equation or whatever common sense, and let's try to do it that way for organizations. The Air Force Surgeon General, as an example. More about the journey, talking about joint operation. We didn't have to really in San Antonio, Brooke Army Medical Center, Army's perspective. There's also Air Force, big medical, and do we really need 2 big towns serving? So, carrying 17, the National Defense Authors, about a few years ago, an agency was formed of taking some of the things like training, like IT and services, but National Defense Authorization and really is changing the game in process now, real time. What they said was, and this is a law signed by the president now, single agency responsible for all the MTFs, Army, Navy, improve access to care, outcomes, and lower costs. All the today of it. But their view was that Army medicine, how good it was, perception, when maybe that wasn't good enough improvement. So this stovepipe military health the turf wars. I will give you an example. I commend pool. We trained from all the service. We trained them exactly the case that we had to pull them with a separate Army, Navy, and record. So bill, they talk about things. Why? Because that's across the whole system. The Army, Navy, and the Air Force. But this is a changer, I think, in health advisory, recognizing the local adapt from the customer. The expenditure is what they emphasize. In fact, they have some areas of category improvement to be made, saying systemization, Air Force medical sub-bullets in this bill that require report. Department of Veterans Affairs, Secretary of Veterans Affairs, Integrated Healthcare System. It has 3 lines of health is one of those lines that did the bulk of it, most noticed by the Congress. 6, where we again talking about systematization, a bunch of resources out of the health system and align them with our hospitals. So you have people, Michael DeBakey, that just to give you some numbers, but about 1 million, they see it's up to about 6 million unique visits a year, 83.6. Yeah, so touch the size of the organization. Close to VAP, 1,000 physicians. And it's had ups in the years. I will tell you, 1996 is a word trend that has been, this book that Jose, it says the best care. Harvard has written, budget office has written about it. Ken Kaiser, who really with taking a hospital to a health system, a bit more about how he used to really now medical center, 919 clinics, vet center, auxiliary residents, vet systems. A lot of capital was, but what he talked about the quality that he cut more than half to open 300 new community, treat 700,000. So it took down the backlog. So what did the business graded service networks, a system that gave each visible region, for which I'll give you an example, just in 21, it's a lot of regions. So the VISN leader, executive service leader, for across sizable healthcare. You'll know that there are I'll drill down on the sense of the Mago healthcare system, there before. There's 3 hospital there in Palo Alto. There's multiple outpatient clinic with Stanford, academic back and forth and forth. So again, system within a system, but standards that and with a lot of I would this system and the success of which is their electronic health. Also make the point years in the making health room. It was built by the grassroots. There's some discussion about should actually find up with that doesn't give you vendor about that separately. What came out of that? It is what this attributed as one of the blow some of that up. Just from 2008 to 2000 changes, important healthcare ventilator assisted immersion infections, and the most snapshot is that it continues moving from 06. This compares the green commercial and Medicaid, and initially it was significantly the outside of the VA at that time, the ability to provide doctors and so forth. So the green box that in 2007, those in the green boxes from the year before. That's a good short period. You look at 2012, and you can see improvement in the VA 2012, 6 years. The difference between Medicaid and you can percentage than what was out because we had the ability to impact grassroots level. For what has been a rich history of research, the Million Man program, which was for moonshot stuff. I've already been working on that. The system, we were able to electronic record to feed it. We have 7 of those, then pump out very high level prescriptions to the veterans, the mail. So we have mail order. We were able, barcode administration, a couple of years, 160 some at that point. They've been able to health and telemedicine. Working down here, it was really our pioneer when I was there. Been part of the system and is now they're putting all of this forward, evolutionary, but moving forward to now 1 million prescription, 1 million patient email, with 2 million telehealth in 2014. One of the most wired, pretty coveted march for care to the patient. Let's talk about the transiting the VA. So I think technology is a fun, but it's really the business process. My Healthy Vet is reaching out with the push bar to provide record into the hands of the, and so that journey from systems, from inpatient, community-based out medical patient, all the PACS, patient care team, home to personal technology, and so. And it continues to change to more into commercial system that can work here as part of our going to have to put in place and referrals to make that happen. Parallels in the civilians. I will tell you that we have what we call the global one, and we try to meet executives who would like to be clients. It's been a couple hours with Lafayette General. A couple. He's been a CEO of hospitals. There may be a message. What I saw, and I think the culture, and thing he talked about, the culture and standards, he talked system, and how, and that, they pick flavor of your choice, but as their EMR, additional hospitals, because they put Cerner in place. He says, I don't need an HIE because the importance of analytic organization, a bit of a micro compared to the same principles that are here, and Explorers. Marching governance. Each has a local fiduciary board, some are more advisory. There is the importance even that different local contexts. One of the things that is common, the leaders are evaluated, and there's the CEO part of each of those other. There's some. I thought it was that he talked about, and that I think goes to the importance of leadership. Right? That every one of our people and we check it. When they greet a patient, that they check off in their mind. This is not unique. Maybe unique is that place is an important down at all I will make eye contact, and I will promote. And he had a little dialogue about each one of these as he. So what is he? Your journey? He went from 2 to 6 owned it and picking up which on this IT, but culture and standing system. Talked to me about putting telemet, which they do have down in the, and so I think it's instructive to kind of a system that we're doing at the regional military and at the regional. So takeaways and look across the observations I've made, underpinned by the outcome. And you heard Ross, and it needs to be standardization. It needs to be sensitive, and then the fundamental information. The importance of technology and the synthesis is important. It takes to support it. Increasing enablement technology that's going all the I think in Louisiana is that they're very proud that they're teaching hospitals. That's fundamental. We graduate medical education it's where you change, help develop the Ross. You got somebody that can replace. And a social determinants of health. As I mentioned, as the health services, I was also rating all that were available to my soldiers. Calicut was real integrated telemedicine and the measure of success students. So that is important in that way. And not to say that they're not, but I'll tell you that's a huge issue. Anything else is really so important. Nothing can be muchizing. Finding the system as large as the needed on the front. There's this about it. If you're on the front page of the Washington Post, above with the fast, offensive, oftentimes, if you're really a good public servant, you do the right thing underneath happen, you're really good, and you'll be left system feeling exposed. And there's plenty of these in our government that impose it. A couple of, George cutting down a cherry tree with, probably if you had that axe, it would probably fall apart. You go to the antique store, 3 new handles, but it's still George Washington's at their system. People move, and so your healthcare system, not necessarily the guy that's going to be for 5 years. 1975, the Army, different than that, but it's the value of the culture, history, and the good of all of those years. So, institution, Washington's Act, depends. You can talk about what I won't. And the other bold enough to move beyond. Ross made the point that we're going to talk about the economic. This is about evolution, but the idea can be, I think, traditional be an instructor notion of George Washington. What's it going to look like in years? So I thank the chair for
Talk loud. Okay. Those presentations and particularly, along with the VA as terms of its results and to what extent, and about the Ontario situation, you have traditional which are now being called in ways that they didn't historically. To what extent is the ultimate being a quasi-military? Which Congress, right? Surgeon General or name is for the VA system, everything flows down. I saw a lot of individual people pushing out in a highly effective. That be replicated, made up of, and we have hospitals as the U.S. Army. They're getting them into a system evident. It's not.
I completely appreciate where you suggest that saying what actors, and we're. I mean, it's within your own level. We're all comfortable with that. I can tell you that's why I struggle right now that the thing with this mandate, you got to be able to figure out how to, how common authority. Here I'm not as it should be. I think you've got service, you've got a combination gets this much, but so I mean that as every system, all those organizations. But the question is, future. Where do healthcare in Montreal look like? What should that your bigger objectives? Where's the leadership that's going in that direction? Clearly, the hierarchy in the military we use. I gave a lecture. I was talking about some years I was Surgeon General. One of the you're a general. And I said, man, it's Army. You've got a purpose at the leader. And I'd say, eventually, the question is, are you going to? That would be my. Yes, sir.
Thank you. Thank you.
Yeah, I stepped out.